since we started using this drug, and we'll be using it more often. These are my disclosures, and the objectives I circulated ahead of time. So talking about the current treatment landscape, the clinical impact of the latest data, and then talk about the discussions around cases, practical management for some of the toxicities that we see with these therapies. So this is a very, very simplified version of what the Canadian landscape looks like for the hormone receptor positive, HER2 negative metastatic breast cancer across lines of therapy. The first line you're all familiar with now, where we favor using a CDK4/6 inhibitor upfront with endocrine therapy for most patients, which that would be an aromatase inhibitor. And then in the second line setting that we are currently offering either endocrine monotherapy, but the AKT pathway inhibitors or PI3K pathway inhibitors that are in the space. And then, whether there's a role for potential CDK after CDK is something we'll talk about. But if they had chemotherapy before, they could then get a CDK4/6 inhibitor with endocrine therapy in the second line setting. So I like to keep it simple, and my mind organizes it in boxes. And this is kind of what I think when a patient has progressed after a CDK4/6 inhibitor. So there are really 6 choices. This is the way I walk through it from an algorithm perspective. So targeted therapies, and this is the part that we're going to focus on today, when we look at the PI3K pathway. So there are PIK3CA inhibitors, there are AKT inhibitors, there are PI3K alpha specific inhibitors. Now, the second column that you'll see here is the endocrine agents. So fulvestrant alone has been a choice that's been favored. Endocrine therapy, I left it broad because some people use everolimus exemestane, some people use everolimus in combination with fulvestrant, although coverage is very sporadic in Canada. I think Quebec is really the only province who reliably reimburses that. And then the novel endocrine therapy agents, which is another hot topic and discussion for another day. I will talk about some of them today. But the oral SERDs, which is, all the rage right now, but also, we're doing a lot of trials with some of these novel drugs. So the Protacs, Serans, Circas, SERMs, novel SERMs, so not, necessarily tamoxifen, but the next generation. The next box here is the CDK inhibitors. So I left it broad again. We know that there's some data now for sequential use. And, in many jurisdictions outside of Canada, we know that this is being used. So ribociclib after prior CDK4/6 inhibitor based on the MAINTAIN study, or the abemaciclib after CDK4/6 inhibitor based on the post-MONARCH. So still some interest there, but then there are also a number of novel CDKs that we're seeing come across in clinical trials and hopefully testing out in the clinic as well. The next box is the antibody drug conjugates. So we know that this has approval currently for patients who received 1 line of prior chemotherapy in Canada, but we know that there's some data now that positions it earlier as the first line of chemotherapy for patients with hormone receptor positive disease. So I don't think this will be for everyone necessarily, and I think that we're looking at some studies for sequencing. Or looking ahead for some of those studies. We don't have the approval in Canada for this HER2 ultra low and for this previously untreated without chemotherapy for the hormone receptor positive disease. Next, we have the PARP inhibitors, which would be in a select group with BRCA1 and 2 mutations. Currently, PALB2 is not included there, although I think it's reasonable to offer to those patients. And then just run-of-the-mill chemotherapy, which, we still use quite often. Capecitabine is a good option and one that I usually favor in these hormone receptor positive patients. So as far as the factors that we think about, one of the important ones that we've seen come out, especially in a lot of the oral SERD data, is the duration of exposure to prior CDK4/6 inhibitors. 12 months seems to be the sweet spot as far as, deciding whether you would offer endocrine therapy or further lines of endocrine therapy. But, if they've had a period of control of less than 12 months, that's probably less favorable and, predictive of lower response for subsequent lines of endocrine therapy. If they had rapid progression or visceral crisis, of course, that would lead you towards a more aggressive, more rapid response type therapy. So usually for visceral crisis, we would still encourage chemotherapy as the first choice. And now the somatic mutation testing is what's really changing in the landscape. And I'm going to talk about that a bit more, but looking at things like ESR1, PIK3CA, actually, now that I'm looking at it, should include PI3K mutations, including AKT and PTEN, as well as the germline BRCA. And then, the standard things that we consider, the patient preference, comorbidities, and access, which unfortunately often guides what we do. So if we look at the real world evidence, so what was the pre-state, before we moved? So this is from the Flatiron database going up to 2020. And patients were treated in the first line setting with a CDK4/6 inhibitor with endocrine therapy. And it was looked at to see what was the documented second line therapy that they received. And here you'll actually see that about 20% of them had already been receiving CDK after CDK, despite the lack of data at the time when this was published. And that's subsequently come out. And then about a third of those patients who would go on to chemotherapy. So there is a significant unmet need of finding additional, targeted therapies in that space post-progression on a CDK4/6 inhibitor. Now, just a note here to say that the first CDK was most often palbociclib, and the endocrine partner was most often an AI. Now, the next slide I put here is not necessarily to highlight the data from MAINTAIN, which looked at CDK after CDK with the ribociclib, but rather just to show how poorly single agent fulvestrant performs. And so you can see here in the patients who had the placebo plus fulvestrant, the median PFS is 2 to 3 months. So this is, technically one of the standard of care next line options is fulvestrant alone, but we're really not getting a lot of mileage from it, which is part of why we want to improve and start looking at things that we can give either in combination with fulvestrant or, beyond for another line of endocrine therapy. Now, I know many of you have seen this slide before, but I think it's good to highlight again that there are 3 primary pathways that we look at for resistance, and some of it that is endocrine dependent and some of it that is endocrine independent. So the pathway that you see on the left, the estrogen receptor pathways, is, all the common things, the aromatase inhibitors, the SERDs, but we're also seeing, a lot of these novel endocrine agents fitting into that space. Now, in the middle, we have the MAP kinase pathway, and you'll see at the bottom, you have the CDK4/6 inhibitors. So definitely some work being done there, especially for mechanisms of resistance and upregulation of things like cyclin D1 and others. And then the pathway on the right, which is the one that we'll be focusing on today, with PI3K, AKT, mTOR pathway, and drugs that target the pathway at different levels. So alpelisib that, was initially reviewed a couple of years ago and positive based on SOLAR-1, but that has never been publicly reimbursed in Canada, so limited availability. The one in the middle, the capivasertib, which recently just went through the Health Canada CDA PCPA process and an agreement in place. So we'll be seeing this come to provinces individually in the coming months. And then the old school mTOR inhibitor, everolimus, that was never selected based on a biomarker, predictive tool. So a lot of these things that are changing. One of the things that I think is important to realize is that, we're starting to think about these targeted things, but there's actually quite a bit of co-alterations, especially between ESR1 and PI3K AKT pathway mutations. And this is one of the challenges that we're going to have. It's just, you have all of these new drugs. They're very exciting. How do you choose? And, a lot of these trials are being done simultaneously or in parallel and don't allow, prior treatment with one or the other. So trying to decide which one you're going to choose is, something that we're all going to have to grapple with. In the top left, you see here the ESR1 mutations and PI3K AKT pathway co-occurrence in first line is about 5% here. But if you look at the bottom right, you're seeing that the co-alterations is actually a lot more frequent, especially if you're looking at PTEN, AKT, PIK3CA. So it does become more common as patients are more heavily pretreated. So there are many combinations of different mutations in these 2 signaling pathways alone. So that leaves us with, a lot of potential treatment options. which is a very exciting time for patients, but maybe more challenging for us as clinicians. Now, this was the ASCO guideline in 2024, and I've just highlighted in the red box here the second-line treatment. And so this is going on the assumption that all patients would be offered NGS, which we know is not necessarily the current, state of things here in Canada. But essentially for ESR1 mutations, they would recommend elacestrant here, which is a drug that has never come to Canada, though there may be other drugs that will be approved in that space, and I'll speak to that later in this talk. There's the PIK3CA mutation, for which you could consider fulvestrant and capi, or for fulvestrant and alpelisib, and the AKT and PTEN, which also renders them eligible for fulvestrant and capi. For the ones with no targetable alterations, you'll see that fulvestrant alone is still listed as one of the preferred options. Fulvestrant and everolimus is listed there as well, though not publicly reimbursed in Canada, outside of Quebec, I should say. And similarly, when we look at the ESMO clinical practice guidelines, you'll see right in the middle there, they have the assessments for this NGS testing. So the assumption is that all patients are getting NGS testing, which is not where we are at now, but that is the vision for the future being within the next 6 months. So a very near future of trying to change clinical practice. So when we look at the mutation diagnostics in metastatic breast cancer, and you heard earlier, I have an interest in personalized oncogenomics and precision medicine for targeted therapies. And in breast, there's actually quite a bit, that we could consider, and some of these new ones. Just wanting to highlight these ones here. So the PIK3CA, AKT, PTEN, ESR1, with high level of evidence for these being, predictive biomarkers for targeted therapies. So I will say that testing should be standard in breast cancer, and we'll talk about the time of testing because I think that will be a moving target as many of these new drugs come to the clinic. But, the biggest challenge that we've had is that testing has historically been tied to drug funding in Canada, which is the primary reason why we haven't had broad access to NGS testing in breast cancer specifically. So moving on to the second objective, I want to talk about some of the latest data and how that fits into the current guidelines, and then think about the testing practices and how we want, the future state to look. So this is a busy slide, but there's a couple of things I want to focus on. So I just pasted the ESMO guidelines, which are a lot simpler than what the CADIF algorithm looks like. But I put in red boxes the things that are new that I think are going to be changing this algorithm. This is from 2023, so it's, a year and a half, maybe just over almost 2 years old, but completely outdated at this stage. So in the top left, I've put here, if they're endocrine resistant, the Inavo 120 triplet. We'll talk about that. And then in the middle box here, I don't know that you can see my arrow, but if they're endocrine resistant, looking at the EMBER-3, so oral SERD data, Emerald, Serena-2, Elaine. So all of those things are coming, as valuable treatment options for endocrine resistant disease. And then in the bottom left, the Capitello 291, which is actually the one that's furthest along in the process of reimbursement in Canada, and something that hopefully will be publicly available in all provinces in the coming months, but currently available through a patient support program. So let's talk about the Capitello 291. So this was looking at patients with hormone receptor positive, HER2 negative advanced breast cancer, men and women, and they had no more than 2 lines of prior endocrine therapy and no more than 1 line of prior chemotherapy, and randomized in a 1-to-1 fashion to fulvestrant alone, which, we've discussed is a reasonable standard of care option, or the one that we have at present, compared to capivasertib and fulvestrant. And there was a dual co-primary endpoint for progression-free survival for the overall population and then the AKT-Pathway altered tumors. So I've put them side by side here. So you'll see that in the overall population, there is a benefit seen with a hazard ratio here of 0.6, but it was a bit more pronounced in the AKT-Pathway altered population, where the hazard ratio here was 0.5. In the overall population, there was a number of unknowns there as well. So, teasing it out, it has been indicated for the AKT pathway altered population. And one of the things to highlight here as well is that patients benefited regardless of whether they had received prior CDK4/6 inhibitor. So a good treatment options for those patients with alterations in PTEN, AKT, PIK3CA. Now, these are the overall survival curves. The data is immature, but looking at these curves early on, it does look favorable. So we're eagerly awaiting updates from that data at future meetings. So this has definitely been one of the new standard of care options that will be implemented in Canada, as I mentioned, in the coming months. But I think that we haven't used it a lot. And so just getting used to some of the practicalities around toxicity management and what to expect and when to expect it, especially because the profile is a bit different than many of the targeted drugs that we use. Moving on, I said that I would talk about the INAVO 120. So I think this is another study that will be practice changing and is currently under review at Health Canada. So this is a niche group of patients who had early relapse disease, and early relapse here being defined as patients who are progressing during their adjuvant therapy or within 12 months of their adjuvant endocrine therapy. Now, you'll see here that the fasting glucose criteria is 6.0 for the hemoglobin A1C, which is quite restrictive. I didn't highlight that with the CAPI earlier, but it was 8% with the CAPI. So, a bit more applicable to the non-clinical trial world. But in the INAVO 120, patients were randomized to the triplet of inavolisib, which is this PI3K alpha specific inhibitor, in combination with palbociclib and fulvestrant, compared to palbociclib and fulvestrant. And, at the time when the study was designed, palbo was still, a reasonable first-line treatment option. So we've favored away from that now for the first starts. But this is what the curves look like. And, I don't have time to highlight as many of the unmet needs as we can, but usually this is a group that does extremely poorly and historically has not presented a lot of endocrine sensitivity when we try to retreat them in the first-line metastatic setting. So you're seeing a very early separation of the curves, good landmark analyses, and, this is only with median follow-up of 21 months with a hazard ratio of 0.43. So I think this is going to be practice changing, currently under review, but will be a very niche population. I know that, thinking about implementing this and thinking about how many patients would be eligible in my clinic, there's not that many who would relapse, especially now that we're treating a lot of these high-risk disease patients in the adjuvant setting with CDK4/6 inhibitors. So I think this is subject to change. Next, I put the EMERALD study here just because I felt like it needed to be mentioned. This is the one looking at elacestrant. And so I mentioned earlier that elacestrant was not brought into Canada, but essentially they were looking at patients who had progressed on 1 to 2 lines of endocrine therapy and 1 line or less of chemotherapy. And they were randomized to elacestrant or investigator's choice for standard of care. The options are listed here, though the majority did get fulvestrant. And you can see here that there was a modest benefit, but really only in those patients harboring the ESR1 mutation, which is how it aligns with the FDA recommendation. So there is a modest benefit seen here, but not something that was brought to Canada, at least in the advanced setting. I think there's some clinical trials that they're trying to bring in the early stage setting. The SERENA-2 is another one looking at an oral SERD, the camizestrant, and looking according to ESR1 mutation status. So they were testing different doses for the camizestrant. For some of the analyses, they ended up putting them together. Ultimately, the 75 milligram dose is the one that's gone ahead for, the next trials that have come in this pipeline. But in this one, patients who had progression after 1 line of endocrine therapy in the advanced setting were randomized to fulvestrant plus CAPI at different doses. And you can see here, I just put in the bottom left, in the ESR1 mutation detected population, you're seeing a very good progression-free survival advantage here, about 6 months. hazard ratio of 0.44. So there are a number of ongoing trials that are stemming from this. So we have SERENA-4, SERENA-6, and I think we're going to be seeing some results from those studies at an upcoming meeting. So, that could potentially change practice as well. Now, one of the things I wanted to highlight here is just, as far as the variants that were detected. So there's improvements seen with the common variants in ESR1, so the D538G, Y537S. So patients with one variant seem to do better than the ones with multiple variants. And, that reflects what we expect in clinical practice with patients with polyclonal disease, likely having more resistance to therapies. And then finally, the most recent one that was presented at San Antonio, the EMBER-3, which was looking at imlunestrant compared to standard of care endocrine therapy. This is a bit of a quirky trial design. This slide here doesn't reflect it super well, but initially was looking at A versus B in ESR1 mutated patients and all patients, and the arm C with imlunestrant and abemaciclib was added later on, but didn't really have a true comparator per se. So in the comparisons that they did, I'll show that to you on the next slide here. So in A versus B, so imlunestrant versus standard of care immunotherapy, there was a progression-free survival advantage, again, modest, but in the ESR1 mutated patient population with a hazard ratio of 0.62. I think one of the key things to highlight is that, the majority of patients were getting fulvestrant, and knowing that they're receiving injections, there's definitely a preference for the oral SERDs. As well as just, having to come into cancer center, getting injections. So I think from the societal perspective, there may be a bit more benefit there. But as a monotherapy, there was no benefit in patients with ESR1 wild type. Now, they then went on to compare the arm C, which was the imlunestrant plus abema, compared to imlunestrant alone. And again, we're seeing a big benefit here. Now, typically in the CDK after CDK trials, we're seeing a 3-month or so progression-free survival advantage. Here, we're seeing about 4 months. Not that I'm encouraging cross-trial comparisons necessarily, but there definitely seems to be some synergy there. So, I think this will be something of interest for the endocrine-resistant population that will come. So, putting all this together, I've just, peppered you with a bunch of slides with all the trials that are currently in progress that we are very excited about as medical oncologists. But how do you bring it all together? So one of the things I want to highlight here is that there's a significant proportion of patients who will not respond to endocrine therapy. And so if you're looking at the Capitello 291 here, you actually see a very, very early separation of the curves with a median progression-free survival of just over 4 months, hazard ratio of 0.5, which this data is from the AKT altered population. Look at Emerald here. You're seeing a 40% drop-off upfront. Acelera here, about 30% drop-off upfront. And the Elaine study, which is with the lasofoxifene, I didn't talk about this one, but again, almost a 40% drop-off upfront. So there is definitely some, change in biology here, especially with the capivasertib, that we're seeing an early separation of the curves and less of that drop-off in the interventional arm. So coming back to what I was showing you earlier with these co-altered patients, one, it's convenient that fulvestrant and capi is the one that's available to us right now, but also that this would be the pathway that I would target first. And I think that data will come on potential sequencing of things, especially for oral SERDs and, targeting ESR1 in patients with PI3K pathway alterations. So this is what I think the state will look like, at least in the coming months in Canada. And just thinking about the time of testing. So on the left is these endocrine therapy naive or sensitive patients. They'll be getting first-line AI and CDK4/6 inhibitor. And at the time of progression, would be getting somatic mutation testing. Now, can you do the testing earlier? Sure, you can. And most of the mutations that we're seeing in PI3K are truncal, so they're likely present already in the primary. In a perfect world, you'd be testing the sample that is the latest one, essentially. But, we talked about the ESR1 kind of coming to the clinic as well. And, that has to be done essentially at the time of progression because most of those are acquired. So assuming that our future state will allow us to test one time, I think that the preference will be to test at the time of progression. Now, as far as tissue and liquid for the PI3K pathway, you might be losing a little bit of the PTEN mutations on liquid, but for the most part, liquid would be a good first step. I think that most of the provinces will be starting with a tissue-based assay, but there is interest in looking into a liquid-based assay as time goes on. And then on the right-hand side for the endocrine resistant, so you'll see here the somatic mutation testing is moved up front. So in those patients with endocrine resistance, which we've defined as patients progressing on their adjuvant endocrine therapy or within 12 months of finishing, they should be getting testing at the time of metastatic relapse. And would likely be candidates for this triple therapy combination, the triplet with the inavolisib. So moving on, this is the part that I want us to focus on. Perfect timing. This is the part I wanted us to focus on a bit more, is on some of the cases and the practical things. I think it's important to highlight the safety profile. I won't bore you with too many slides, but just some real world cases and what to expect with them. So this is what the toxicity profile looked like for the Capitello 291. So you'll see that about 13% had adverse events that led to discontinuation here. Dose interruptions in about 35% and dose reduction about 20%. The biggest thing with this drug is the diarrhea. Now, fairly low grade for grade 3 diarrhea, but still just under 10%. The nausea, which can sometimes be bothersome. Rash is the other big one. And I think rash is one of the ones that people struggle to manage a bit more. Like, we're not seeing a ton of rashes with a lot of the other targeted drugs, at least in the breast world. I know that it's probably common with other tumor sites. So those are definitely the primary ones that we're seeing. Now, I do want to highlight some of the toxicities of special interest here. DRESS, erythema multiforme, palmar-plantar erythrodysesthesia, which they've listed here. They didn't actually report any here. The hyperglycemia rates, which are significantly lower, and I'll show you side by side what that looks like with alpelisib, which is the other drug that you could consider for the PIK3CA mutated cancers. Very rare for DKA, but it can happen, and acute kidney injury, which was low. So just putting these side by side, what does that look like? So I've already mentioned that for the capivasertib, the diarrhea and the rash are definitely the most common, and nausea that comes afterwards. Hyperglycemia, about 16%. Now, if you put that in contrast with the alpelisib, you're seeing that the hyperglycemia rate here is like 65%. And this is in a clinical trial, patient population. So the most fit of patients that you can have. So implementation of this in clinical practice has been quite hard. And I know that, some have used alpelisib and I've used it, but I don't love using it, mostly because it's so hard to manage clinically. So I think it's important for us to learn early how to manage the toxicity and be comfortable, and knowing what to anticipate. Some of the other things that I'm going to talk about, so the stomatitis is about 15% here with the CAPI. It's about 25% with the alpelisib. And then I put everolimus at the bottom, but this is an unselected therapy and not funded across most jurisdictions. So I don't think that we're going to focus on that too much. So this is the first case that I put here. So she's a 57-year-old patient who had an early stage breast cancer about 5 years prior, and then presented to me with an unresectable locoregional relapse, just kind of tracking along the brachial plexus back in June of 2019. We were able to get a biopsy and confirm that it was ER positive, PR weekly positive, HER2 1+ negative, and her genetic testing was negative. So she was started on letrozole and palbociclib at that time, June 2019, ended up being dose reduced over the years, mostly because of neutropenia, but essentially tolerated that well. And then in October of 2024, presented with increasing hip pain and found to have bone metastases on CT scan and bone scan. Because it was in the bone and fairly deep in her pelvis, we're actually unable to do a repeat biopsy. And one of the things to highlight here is that bone biopsies can't be used for mutational testing. So we were looking back to see if we could get it from the original primary biopsy that she had. Unfortunately, the sample wasn't adequate. The tumor content wasn't good enough to send. And so trying to think about the options and knowing that we have a lot of these targeted therapy options, she elected to pay for Foundation 1 mutation testing, which is not cheap. But ultimately, she was found to have PIK3CA mutation, one of the common ones that we see, and P10 loss. And so she was started on second-line fulvestrant capivasertib in December. So I put the dates here because I think it's important just to recognize what days to expect some of these toxicities. So she started on December 31st, arguably not a great day to start a new therapy, but she was just eager to get going as soon as possible. And then I usually set up weekly calls for them with our nurse, which I realize we are very privileged to have, access to team-based care nurses who are able to do those weekly check-ins, at least for the first month. So week 1 was fine. And then week 2, when she called her, she had low-grade nausea that had started on day 1 and at the time didn't seem to bother her too much. But, low-grade nausea, I think, is one of these things that we underestimate the impact on the patient and, day-to-day life. So that was somewhat bothersome. She had a few mouth sores that had started on day 3. And she had diarrhea that was starting on day 8, 3 to 4 loose bowel movements per day with some cramping. And she was very reluctant to use Imodium because she had been constipated her entire life and so was worried about going into constipation. So she was prescribed prochlorperazine to take with capivasertib, the dexamethasone-based mouthwash. And so she had declined prophylactic use. And I'll come back to this in a minute. But, now, especially for patients who have extended drug benefits coverage, that I do offer it prophylactic. And the Imodium, which we told her to take 4 milligrams up front and then 2 milligrams afterwards for each loose bowel movement. So focusing on the diarrhea for a minute, she fits into the grade 1 here. So the increase was less than 4 stools per day over her baseline. And so she was started on the loperamide schedule, but you can see here there's clear guidance on when it should be held. Essentially, if you're getting into grade 2 or above, that we are interrupting capivasertib. And, in the protocol that we're launching provincially, this is how we've written it, which is slightly different than the product monograph, which says you could probably, continue it if they have grade 2 and just reassess within 24 to 48 hours. But, I do worry, especially for those who have never used the drugs, that might not go well. So erring on the side of caution right now, for use in BC, we are going to be recommending interruption when they get grade 2 toxicity. If symptoms improve to less than grade 1 within a month, then they can resume at the same dose level. If it persists, then we would decrease 1 dose level. If they have grade 3, then you would interrupt it right away, start the anti-diarrhea treatment, and you would restart at the lower dose level for the next one. Grade 4, so life-threatening consequences, which I have not seen, thankfully, but that would be a permanent discontinuation for the capivasertib. So for this case, cycles 2 and 3, she was assessed, and for the stomatitis, it resolved. She used the dexamethasone-based mouthwash for about a week, and then she started using it only during the days of capivasertib for cycle 2. And then she stopped it at cycle 3 and didn't have any recurrence of the mucositis. The nausea, she was taking the prochlorperazine fairly routinely with cycle 2, and then similarly stopped it around cycle 3 and has been able to manage without. And then the diarrhea started to settle around the 8th week or so, and she required about 1 to 2 doses per day, so 2 milligram dose in her cycle 2 and got better. So proactively, what would we be doing differently? And I think this is all, the learning curve that comes with it. So, a lot of patient education around the antidiarrheal. There's really no advantage in well, I don't give it prophylactic upfront, but very, very early reactive, meaning at the first sign of loose stool that I would recommend they take Imodium at that point. And I put a note here. I encourage patients to take it with food. In the product monograph, it says with or without food, but I find that when they are taking it with food, it seems to be a bit better digested. Increasing oral fluids, which is important, modifying, diet, electrolyte supplements as needed. And of course, the communication piece and, making sure that they know who to contact when they have the diarrhea. So the median time to first occurrence was 8 days. And actually, it's almost like she read the textbook, but her diarrhea started around day 8. I mentioned earlier that the rates of grade 3 toxicity were under 10%, though I think that we are likely to see higher numbers in the real world. And I put a note here that increased diarrhea is seen with metformin. The hyperglycemia is not a common thing here, but something to think about in the back of your mind. And especially that with severe diarrhea, they can get dehydrated, kidney injury, and with metformin too can get lactic acidosis. So a lot of potential, red flag things that need to be monitored, and patients need to be well educated on how to use this drug. For the stomatitis, so this is an extrapolation from the data with alpelisib. So I mentioned earlier for the alpelisib, the rates of mucositis is about 30%. With the capivasertib is about 15%. Very few who go on to develop grade 3. So usually it is low grade. I have been recommending the prophylactic steroid-based mouthwash. It is fairly expensive. So I think for the patients who have, extended drug benefits program or the means to get it, that, it would be a no-brainer and I would use it. For others who prefer to hold off and see how it goes, I think that's reasonable as long as it's introduced early. But usually we're seeing this stomatitis happen fairly early, like in the first 1 to 2 weeks. And then we, this is something that I've put on the handouts that the nurses go over with the patients. But just like oral hygiene practices, which we don't necessarily talk about a lot, the things that might irritate the mouth, like hot, spicy, acidic foods, all of those things that could be potential irritants. And then the homemade mouthwashes, which are a lot cheaper than dexamethasone-based ones. And I've had a lot of patients who've been fine with just the baking soda and water rinses. So, I think it's reasonable to consider either way, but a really low risk of harm for the prophylactic steroid-based mouthwash. And it works really well. If we look at the SWISH study, which, admittedly was done with the alpelisib, but the rates of grade 2 or more stomatitis went down from 33% to 2%. So definitely a very effective drug there. So moving on to case 2, which is the last case, and then we'll have some time for questions. This is an 89-year-old patient. She is one of these Vancouver special, very fit and healthy patients, but who had a T2N2 grade 3 tumor that was strongly ER/PR positive and HER2 negative in May of 2021. She was treated with surgery upfront. In hindsight, would I have given her neoadjuvant chemotherapy? I don't know. She was 89, so I don't think that we necessarily anticipated this much nodal disease, but that's a separate discussion. And so she was referred for adjuvant discussion, and on staging, investigations was found to have enlarged mediastinal nodes and a small pleural effusion. She had an endobronchial ultrasound and biopsy, which confirmed metastatic disease and consistent with the primary. So she was started on first-line letrozole and ribociclib in July of 2021, eventually was dose reduced over the years, primarily due to cytopenias, but well tolerated overall. And then in March of 2024, was found to have progressive disease in the lung, liver, and bone. She had a repeat biopsy of the liver in this case, and it shows some ongoing estrogen receptor positivity, though less than the original. PR was negative, and then the HER2 was 2+ by immunohistochemistry, negative by FISH. So she had NGS testing. We used the tissue from this repeat biopsy, sent it to APL, the Alberta Precision Lab, which is one of the diagnostic testing access programs that we have available to. And she was found to have a PIK3CA mutation, again, a common one that we see, and then some other markers for potential resistance to endocrine therapy with a cyclin D1 amplification. And she also had an ERBB2 mutation, which is interesting finding for another day. But she was started on second-line fulvestrant capivasertib in June. So again, I put the dates here. She was started on June 5th. She called in with June 17th, and I just put in the excerpt of what the call was to the nursing line. So rash started Saturday evening, neck, chest, upper back, and the bottom of her scalp. She said the rash is raised, circular bumps, large areas of red blotches, no pustules, no blistering, itchy but not painful. And this is what it looked like. I couldn't actually get her consent before this talk to use her picture. She sent me pictures, but this is what it looked like, just predominantly to the upper chest, upper back, neck area. So looking at the rash with capivasertib, so this was just under 30% of the body surface area here. And so we called it a grade 2 and started topical corticosteroid therapy. I'll go back to the case afterwards, but you can see that there's very clear guidance. And for rash, this is just based on the CTCAE version 5 criteria. But, there is good guidance out there. And so for this patient specifically, she was started on a non-sedating antihistamine. Again, this is one of the things that I had recommended prophylactically, but because it's over the counter and, just the cost associated, she had decided to see if she needed it or not. And she was prescribed topical corticosteroid for use to the upper body. We called her 48 hours later, and at that point, the rash had extended to the upper thighs and just down to the back of the legs. She's very itchy, very miserable. So she was prescribed prednisone. So I kind of used like the PMR dose, 20 milligrams once daily, and gave her a prescription for 7 days. Her rash actually resolved within 2 to 3 days. So it was a very, very quick, rapid, satisfying response. And then she was seen 2 weeks later. So the capi was held for 2 weeks. The rash was completely gone. And so I reduced her dose level -1, and she actually never had any recurrence of the rash. And it was the patient I actually just saw recently, earlier this month, and she's still on treatment, still responding well. So despite the fact that, she's an older patient, potentially at higher risk for complications, she's actually done really well. So I wouldn't shy away necessarily from treating patients solely based on age. I think it depends on how the person looks, and just good communication, which is, I think, where we see more of that vulnerability is from around the communication piece and access to care and things like that. So when we think about the proactive measures to address the rash, this is based on the alpelisib guidance, but looking at prophylactic non-sedating antihistamines for 8 weeks, and this is something that I routinely offer to patients now. One of the things, not so much of a problem these days in Vancouver, but, sun exposure is definitely one of the aggravating factors for the rash that we're seeing. And a lot of irritating skin products, especially around the face, for these alcohol or salicylic acid based products. And then just general education around, using sunscreen, mild fragrance-free soaps, all that good stuff. So all grades for rash was about 38%. Grade 3 was about 12%. And the median time to first occurrence was about 12 days. This patient was 13 days. So, I think for what's been reported aligns with what I've seen in clinical practice as far as the time to onset of symptoms. But it tends to be very early, which is why it's important to do all of the good education and, hands-on practical management early. So we mostly see maculopapular rash. So in all the rashes that I've seen with the capi so far, it's been maculopapular, but just keeping in mind that there are, more severe skin toxicities that could occur. Rates are low, probably about 2% or so, but still keeping that in the back of your mind. As far as the rash management, these are some of the things that we've used. One of the things I found quite helpful is the hydroxyzine. So it's a sedating antihistamine, but especially at bedtime for the pruritus, because people are really miserable, when they get the full body rash. Usually that works well, and hopefully they just need it for a couple of days. There is some data for gabapentin. That's mostly when they have the burning or stinging feeling with the rash. I haven't had it as much, specifically with capivasertib, but something to consider in the back of your mind. And of course, systemic corticosteroids. It says 0.5 to 1 milligram per kilo daily. To be honest, for this patient who is, older, a bit more frail, I didn't want to give her very high dose steroids, and 20 milligrams did the trick. She had it for a week. So just some practical considerations there. There is a good paper that was published by Dr. Rugo and Dr. O'Shaughnessy, which was, looking at optimizing care of patients with alpelisib. A lot of it is on target effects. And so, I think that a lot of these can be extrapolated from one drug to the next. But the incidence is going to be different across the drugs that target the PI3K pathway. In this, they do recommend consulting a dermatologist for refractory grade 2 or any grade 3 adverse events. I think it's very center dependent on how much access we have to dermatologists. But, if you have access, something to consider. And then the last piece here is just touching on, how do you monitor these patients? This is what we've included in the protocol at BC Cancer, but they will get fasting blood glucose every 2 weeks in month 1. Initially, we looked at doing it weekly, but honestly, the rates of hyperglycemia are not that high. So, in patients who are at high risk, and it's important to ask about those high risk features, but patients who've had already an abnormal fasting blood glucose, or elevated hemoglobin A1C, or, they're on steroids, they have concomitant infections, or a history of diabetes. Those are patients that you want to watch closely. And then the hemoglobin A1C every 3 months. And then the clinical assessment for the bowels, the skin, the stomatitis. Those should be part of the standard questionnaires. For the hyperglycemia specifically, I just I'm in the process of finalizing this protocol that we're developing for the capivasertib. This is what we've put around the fasting glucose monitoring. So essentially for grades 1, we would continue capi, but grade 2 onwards, I'm actually going to change that, but to hold the capivasertib and initiate anti-hyperglycemic agents. So I've put the common ones here, and I don't pretend to be an endocrinologist, but usually metformin's one that most of us are comfortable starting. So that would be the first line agent for most patients. Usually I would start them on 500 milligrams twice a day, and then increase it to 2 pills in the morning, and then 1 in the afternoon, and then 2 and 2. So ultimately ramping up to 1 gram BID. And for most patients, I've been able to stop there and haven't had to increase beyond that. For the metformin, I put the caution here for the lactic acidosis, and it can exacerbate diarrhea. So I think that's one of the things to monitor very closely, especially with CAPI. The SGL2 inhibitors would be the secondary agent. And so that one, there is increasing support for the, addressing the on-target effects for PI3K drugs. It's important that they know to hydrate well. And then also, especially women are at higher risk for yeast infections, which is something that I've seen with this. Usually when I'm starting to add the second agent, I tend to try and get endocrinology involved. And there may be a time in the future where we feel more comfortable managing these on our own. But I think it's okay to ask for help early. The DPP4 is another choice, pioglitazone, which, we don't use as often, but mostly focusing here, the sulfonylureas are not recommended, and insulin would only be reserved in the case of like DKA or HHS or, severe hyperglycemic syndrome. So I think that's all the toxicities I wanted to put there. So I wanted to open it up to questions and see if there's any specific, questions, practical considerations, new data questions. I'm open to all things.
Thanks, Natalie. That was, a phenomenal review of the data, and it was really nice the way you incorporated the clinical cases as well, making it very practical. So I'm going to open the floor to questions. Feel free to either, unmute, raise your hand, or you can also put your questions in the chat. Dr. Fernandez,
Yeah, hey
you
Natalie.
unmuted.
Hi.
Yeah, that was a fantastic lecture. So easy to follow. Thank you so much. Natalie, we have seen some referrals for patients with PIK3 mutation after CDK inhibitor for clinical trials consideration. Do you feel that is there room for clinical trials in these patients, or it's second line capvasertib and that's it? How do you see
Yeah,
this?
I mean, I think it depends on the trial. I didn't actually put the case here because I didn't want to get too complex, but I've actually had one of these patients who was eligible for 3 trials. So we had one of the ARV trials, we had one of the Elaine trials, and then she was also eligible for fulvestrant and capi. And she's trying to decide, and she had this co-alteration of ESR1 and PIK3CA, and we're trying to decide which one we're going to give her. And it ultimately, in my mind, it comes down to the PI3K usually having a worse prognosis. So that's usually what I would favor over the ESR1 first. And this is completely off label, full disclosure here. But, I think that with the EMBER-3 data coming out and looking at the imlunestrant with abemaciclib, I think that there would be interest in potentially using that after fulvestrant capi. There is no data at all. So, just full disclosure there. But I would try to target the PI3K pathway first. Now, if you had a trial that, allowed you to use an oral SERD with the PI3K pathway agent, that would be fantastic. And I know that there's a lot of those that are currently in development. So, but I think it depends on what the trial is and what's available.
So much.
Great question. And I think as we're answering, asking questions and answering questions, please see the QR code for evaluation today. There's also a link in the chat for the evaluation. I think, one of my questions, Natalie, actually, you had mentioned, I think in the first case that there was I think it was a proactive nursing call to the patient to see how she was doing on the capivasertib. Is this something that you've routinely done at your center? And if so, how have you rolled that out?
Yeah, so we have a team-based care model, and actually recently, we've moved to a provincial nursing line for a lot of the patient call-outs, which frees up our nurse to do more of these clinically oriented tasks. So I routinely get the nurses now to do a call-out at week 1, week 2. Usually by week 2, if they're okay, then we would drop further calls and they would just come see me back at cycle 2, day 1. But I think having that early identification of symptoms is key to being able to manage them early and prevent them from getting worse. It's one of these things in the clinical trials where we're seeing these rates, but we know that in the real world, there's differences and we're seeing a higher proportion of some of these toxicities. So we have been routinely doing it for the patients starting on CAPI. But again, I realize that we were very lucky to have that support staff. I think it's just more from the community, perspective, or, if you're starting treatment and they're not necessarily seen by you the entire time, just having that early education is going to be key.
And then these calls are being done like day 8 or day 14?
So day 8 and day 15. Usually the day 8 is just a check-in to make sure that things are going okay. So that one usually tends to be a quick one. The day 15, I actually get the nurse to review labs, and they just flag it for me if it's abnormal. It gets flagged in my inbox anyways, but it's that second measure of double checking because we're checking sugars and we're checking kidney, liver, just the usual panels. Um, it's been going well so far, and most patients past week 2 have been okay. Like I haven't really had to institute more patient calls. It's just really in that first 2 weeks to get them on.
Are there any other questions here? Maybe I'll ask just one more. I mean, in terms of the diabetes piece of it, we saw that you mentioned the criteria for enrollment in terms of the HbA1c cut points. Would you consider using a PI3 kinase inhibitor in somebody with established diabetes who's already on metformin?
It depends how well controlled they are. So the short answer is yes, as long as their hemoglobin A1C is in a reasonable range, and that they're managing well with their metformin and they're reliable. In diabetic patients, I've only done it once with a CAPI, so I can't speak broadly to how well that's going to go. But I was making sure this person was doing their blood sugars at home, that they were doing their fasting blood sugars, so just like point of care testing with their little machine, at least every 3 days, and getting them to keep a diary of it. And if we saw a rising trend as far as their fasting blood sugar, that we would then halt or decide what to do at that point. This person was very, very motivated and, still quite active, like physically active. Like I think a lot of the diet, exercise, all the other stuff that's definitely important as far as the glycemic management too.
Excellent. So I don't see any, I seem to have lost access to the chat. So I'm going to stop sharing my screen. I don't see any additional questions. So thank you, Nathalie, Dr. LeVasseur, so much for that excellent overview and case-based discussion. Really fantastic. And thank you to AstraZeneca for organizing this and for funding the lunch for us as well.
Yeah, thank you so much for having me.
Thank you both.
Bye.